one is in the cytosol. And we're going to talk about that because that becomes important when we measure and assay for B12 deficiency. Now, B12 is found in our diets. It's found in meats, lamb, mackerel, crab, fish, eggs, milk, clams, liver. And human beings, our colon synthesizes B12, but because that's after where B12 is absorbed, we can't absorb bacterial form B12, unlike ruminants. So cows actually can, essentially the bacteria in their gut can synthesize B12 and they can absorb it, but we can't. And that makes us obligate to have supplemental B12 in our diet. So we can't make it, so we have to eat it in one of these food sources that I've listed. So the biochemical reactions that require B12 are transfers of methyl groups and also hydrogen atom transfer. And I don't want to belabor this much. This brings us back to our first year of medical school. But I just want to point out that, if this works, let's see. Yeah, that B12 is important for the conversion of methyl tetrahydrofolate to tetrahydrofolate and also for the conversion of homocysteine to methionine. And to jump ahead a little bit, the reason that's at all important, aside from taking tests your first year in medical school, is that if you're B12 deficient, you're going to have elevations in homocysteine and also in methylmalonic acid. And that's a foreshadowing for, to talk about the best way to assay for B12 deficiency. So when we take in B12, it's absorbed in the terminal ileum, and B12 absorption is facilitated by intrinsic factor, but in fact, mass action allows us to absorb about 1% of the B12 that we take in our diet. And the reason that's important is the right way to replace B12 deficiency in almost everybody is by mouth, right? So there's really not a role for parenteral B12, and we're going to talk about that. Okay, the receptor is called cubullin annulus, and that's only important because there's a congenital disorder where that's absent, but that's rare. Okay, so what happens? How do we absorb B12? Well, what we do is we take in foods like the list that I showed you that contain B12. And in our stomach, gastric acid and proteases release B12 from foodstuffs. Now, B12 needs to be stabilized in an acid environment, and it's stabilized by R proteins, not by intrinsic factor, but by R proteins in the stomach. Salivary haptocorin and cobalophyllin are two of them, and these protect B12 in the acid environment. So it's broken down from food, then stabilized in the stomach. Then what happens is, in the alkaline small intestine, the R proteins are removed, and what happens is B12 binds to parietal cell-formed intrinsic factor. The intrinsic factor B12 is protected by, from bacterial degradation and is absorbed in the third part of the small intestine, or the ileum. Now what happens then is B12 is absorbed in the ileum across that cubullin receptor, and then it's bound to transcobalamin 2, where it's endocytosed in the cell and stored in the liver. And one of the important teaching points here is that because of the enterohepatic circulation, if one had normal B12 levels and became a pure vegan and didn't eat any of the foods that I showed you, it would take a decade to become B12 deficient. So you don't become B12 deficient from a short-lived fad diet. That just doesn't happen. And this is a cartoon showing that. So what happens again is haptocorin from the salivary glands is released, and in the stomach, when B12 is released from food, B12 is bound to haptocorin, which stabilizes it in the acid environment. Then what happens in the first part of the small intestine, when it's alkalinized, haptocorin is released and B12 binds to intrinsic factor. Then in the lower small intestine, this B12 intrinsic factor binds to the cubullin receptor and is absorbed. When it's absorbed, intrinsic factor gets degraded and B12 is bound to transcobalamin. It's taken up by receptors and then enters into the cell. And the two places where B12 is important is in the mitochondria for the conversion of methylmalonic-CoA to succinyl-CoA, and in the cytoplasm, as I've shown you before, where it's involved in the conversion of homocysteine to methionine. So that's what happens with B12 normally. And when we talk about B12 deficiency in the cases in a couple minutes, we're going to use this basic biochemistry and physiology to understand how B12 deficiency arises and how we can perhaps treat it. So let's now forget about biochemistry and let's get back to the case. So if you remember, this was a middle-aged person who had diabetes on metformin with a low normal, but normal serum B12 levels, but pancytopenia, some increased bilirubin, increased LDH, really consistent with a diagnosis of B12 deficiency. And importantly, remember that since B12 is necessary for normal erythropoiesis, this ineffective erythropoiesis that occurs in the setting of B12 deficiency leads to some intramedullary red cell destruction. So increases in bilirubin and LDH are very common in B12 deficiency. And in fact, some of the early reports in the late 1800s of hemolytic anemia were in fact B12 deficiency, right? Because that was a bit more common. But I can't be a hematologist and not show you a peripheral blood smear. This is a classic smear for B12 deficiency. Normally, a poly has 4 lobes, or up to 20% can have 5 lobes. You can count, we're much greater than 5 here. These are very large red cells, and there's some really kind of abnormal shapes and forms, and this would be consistent with B12 deficiency. Now, how do we assay for B12 deficiency? So the first big take-home message I want from today is that the serum B12 level is not a good test. In fact, I don't send serum B12 levels. Why? Because the serum B12 measures serum B12, but not tissue level B12, which is really what you're interested in. And there's a large population of patients that have been described for at least the past 40 years who, for all intents and purposes, are B12 deficient, yet their serum B12 levels are in that normal range. So if you remember some of the biochemistry, the better tests for measuring B12 deficiency are actually to look at a serum methylmalonic acid level and a serum homocysteine level, both of which are increased in B12 deficiency. These are the tests we should be setting, okay? And if you look, if you're B12 deficient, this is where cobalamin lives, and you can't convert methylmalonyl-CoA to succinyl-CoA, you get an increased level in methylmalonic acid. Similarly, you get an increase in homocysteine because of an enzyme deficiency in that pathway. So, take home point 1, don't look at serum B12 levels, look at MMAs and homocysteines, both of which are elevated in B12 deficiency. Now, again, this is just another cartoon showing you that methylmalonic acid and homocysteine are both increased with B12 deficiency. And I'm going to show you some data that these are in fact better tests for B12 deficiency. Now, I find when I see patients who have had B12 levels, again, I don't check them. If they're less than 400 or 500 and look like they may be B12 deficient, you got to check these tests. There's a paper in the literature titled Time to Abandon the Serum Cobalamin Level, and there's many papers and publications showing that the methylmalonic acid is sensitive and specific for B12 deficiency. Now, one thing that comes up, I have an MBA, my students are smart, they say, well, yeah, but how much more expensive is this than a B12 test? Well, a B12 test costs about $50, an MMA costs about $100. You don't need the homocysteine. It's a little bit more money, but with the cost of healthcare, I'm going to argue $50 really isn't a lot to worry about. And it's a much, much better test, because if you get the serum B12 and it's 400, you need the MMA anyway. So why even get the B12 level? Again, check MMAs and homocysteines, not serum B12 levels. Okay, an elevated MMA in the nutrition literature is associated with worsened mental status in the elderly. And as we've known, when we fix B12 deficiency, the neuropsychiatric changes that we see are not always improved. And that's in fact true in patients with an elevated MMA as well. So let's get back to our patient. Our patient is 52, diabetic, on metformin, and the question is, why is the patient deficient? And does it matter? Perhaps is even a bigger question. But most patients who are deficient in B12 are deficient because of malabsorption. Now that may be because of pernicious anemia and autoantibodies to intrinsic factor, it may just be related to other things, but it's almost always malabsorption. There is an association with pernicious anemia with Hashimoto's thyroiditis, so that's important because when I see patients with Hashis, I got to think about B12 deficiency and vice versa. Several years ago, maybe many years ago, I was involved in a case in a very young child, an infant in fact, who wasn't reaching normal milestones of development. And mom had a diagnosis long-standing of Hashimoto's and was replaced with levothyroxine. And because of this association, the patient had genetic tests that were normal, but I said we need to check a B12. And in fact, the child was pretty profoundly B12 deficient, was replaced, and fortunately was replaced in time, that there wasn't irreversible neurologic damage. But remember, with pernicious anemia, the neurologic damage is not necessarily reversed when we replace B12. The anemia gets better, but the neurologic stuff may in fact not completely normalize, especially in an infant. So that association is robust and important to remember. So pernicious anemia is characterized by antibodies to parietal cells, and these antibodies in fact target the alpha subunit of the potassium hydrogen ATPase. If you measure these antibodies, they're found in 85 to 90% of patients with pernicious anemia, but unfortunately, they're also found in about 20% of the general population. Because of that, there's a limited specificity and for disease. It's found in diabetes and thyroid disease and other things, and it doesn't affect treatment. So I never send these. You can also, though, send anti-intrinsic factor antibodies. Those aren't much better. And because the treatment doesn't depend on etiology, I personally do not find these tests particularly helpful because of their lack of specificity. And really not very good sensitivity either. Was that a question or no, just a yawn? Okay, yeah. So I don't find these particularly helpful, but you can order them and they do exist. So what's the best way to replace B12? Well, remember what I told you, that even in the complete absence of intrinsic factor, about 1% of our B12 that we take in can be absorbed across the ileum just by mass action. So as a result, oral is a better replacement. Why? It's cheaper, compliance is better, and there's really, and it's easier to give. There are reports that go back now some 30 years about the ease and benefits of oral versus parenteral B12. An editorial in 2003, the title was "Oral Vitamin B12 Can Change Our Practice." So there are some indications for parenteral B12, but they're few and far between. Nearly everybody can be replaced orally. Patients prefer that. It's cheaper, compliance is better, and it's easy to do. Now, there are other preparations of B12. There's nasal, there's sublingual. Absorption is variable with those, especially with the nasal, and they're not better than oral, and they're more expensive. So really, oral B12 is what we should be using. When I see patients on parenteral B12, I ask why. Why are we doing this? We've known for maybe 30 years that that's not the best way to do it. In 2018, a Cochrane review concluded that both routes are effective in raising B12 levels, with oral B12 being easier and cheaper. And another review from 2006 found that oral B12 was equivalent or better for raising B12 levels, correcting anemia, and resolving neuropsychiatric findings. So again, data in the literature, Cochrane data, evidence-based reviews, that we really shouldn't be using parenteral B12 unless the patients truly have a problem with their ileum. So if you don't have an intact ileum, then you're not going to absorb even 1%. So if you have ileitis, or have had surgery, or have a genetic disorder where you don't have a receptor, those are the patients that need parenteral B12. But those are few and far between, and really we should not be giving parenteral B12. So suppose Suppose there's a couple people my age in the rooms, and the younger folks haven't seen this or done this, but this is an important case. So the patient that I described, who's 52, is replaced with daily IM, cyanocobalamin, 1,000 micrograms for 6 days. The patient becomes bradycardic and hypotensive. And I want you to look at the EKG, which doesn't project really well, but I had a different version of this talk. But what I want to draw your attention to are these, flipped T waves and prolonged QT. So this is, in fact, what electrolyte disturbance? Is there students in the room? Somebody? Yeah, so this is hypophosphatemia. So patients who are B12 deficient, who get replaced, can develop a pretty profound hypokalemia. Hypokalemia is what they get. I might have said phosphatemia, I meant hypokalemia, okay? Really important. You need to recognize this. You need to look for this, because that, in fact, can be life-threatening. Again, it's from rapid hematopoietic cell synthesis. Remember, potassium is an intracellular cation, and it can be life-threatening. And patients who are profoundly B12 deficient really probably should be on a monitor for 24 to 48 hours when you replace. Okay. So how do patients respond if they're B12 deficient? Well, the first thing that happens is bilirubin, iron, and LDH fall within several days. Iron falls a little bit because it's being consumed. Within 12 hours, megaloblastic changes resolve in the marrow. You get a reticulocytosis in 3 to 5 days and a normalization of hemoglobin in about 2 months. Hypersegmentation can occur for a couple of weeks. And one of the important take-home messages is, if you replace folic acid in somebody who's B12 deficient, you can correct the anemia. But what you can't correct are the neuropsychiatric changes. So if we diagnose somebody with folic acid deficiency, which is rare in the United States because our grains are supplemented with folic acid, but if you replace somebody, it's very important to make sure that they're not B12 deficient, because the neuropsychiatric disturbances can persist. And then again, don't forget the potential for hypokalemia with response in patients that are severely deficient. Has anybody in the room seen somebody severely B12 deficient? Probably some of the folks up my age. I mean, yeah, I've seen patients who've been frankly psychotic or almost comatose, and you give them B12. It's almost like when you give levothyroxine to someone who's profoundly hypothyroid. It can be, the resolution is fast and actually remarkable. Okay. So what happened to this patient? The MMA and homocysteine were both elevated. The patient was put on oral B12 and had resolution of cytopenias. And that's what you would expect. Now, one thing that's important, when I said you can replace B12 deficient patients with oral B12, you're going to use a dose of about 1,000 micrograms a day. Unless you think that's a high dose. I have a picture, and this is not the same version of the talk, but I came home a couple weeks ago and my wife on the shelf had a bottle of B12 gummies that she brought at CVS, why I don't know, and those were 1,000 micrograms. So 1,000 micrograms is not hard to get. It's found just over the counter. It's found in gummies, and that much will replace B12 deficiency in nearly all of your patients, and it's cheap and easy to get. Okay, so let's go to another case. A 42-year-old woman has had low B12 levels for the past decade. She has not had a history of anemia, macrocytosis, or neurologic symptoms. It's a real case. MMA and homocysteine levels have been normal. She's on no medication. She's tried various B12 formulations. Several, like the nasal, have not been well tolerated, and they haven't increased her B12 levels. So what is going on? So the question is this patient B12 deficient? Okay, is the patient B12 deficient? So this patient was sent to me because they're not responsive to supplemental B12. But what did I tell you about serum B12? Right, it's not a very good marker. And in this patient, the MMA and homocysteine are normal. So no, this patient is not B12 deficient, right? So probably doesn't need to see me and isn't cytopenic. But the question is why, right? So let's think about what I showed you in an earlier biochemistry slide, where B12 is bound to transcobalamin 2, right? Well, it turns out there's also a transcobalamin 1 and 3 that we group together that bind B12 but can't allow B12 to enter the cell. So they're carrier proteins. And guess what? There are patients deficient in those, and their total B12 might be low, but their tissue B12 is just fine, and they don't need treatment. And that's what happens here. Haptocorin is also called transcobalamin 1 and 3. We lump them together now. It carries about 70 to 90% of the B12 in serum, but it's not available for the cell itself. It's just a storage protein, a transport protein, if you will. Only transcobalamin 2-bound B12 is available for hematopoietic cells, and you really don't need to treat these patients. So if a patient has a low serum B12 and normal MMA and homocysteine, they're not B12 deficient. They don't need treatment. You don't need to remember the biochemistry, but just realize they don't need treatment or intervention. Okay, case. A 58-year-old man was noted to have a white count of 27,000 on a CBC obtained at health fair. Why they're doing them, I don't know. The remainder of his CBC was remarkable for a hemoglobin of 12.7, a platelet count of 532,000. His physical exams remarkable for mild splenomegaly, and a serum B12 is checked and is found to be 2,000, right? So it's really high. So the question is, who in the room has seen somebody with, an elevated B12 count? You ever seen them? So the question is why, right? And does this matter? Is it something we should be actually concerned about? So the first question is, how do we measure B12? Remember, I've told you it's not a good test, but when we send it, how do we measure it? What we do is in a blood sample, we remove B12s from protein, we convert it to cyanocobalamin, and then we do a radio competition assay using bacteria. So you can imagine if we're doing a test like this, or even if we're doing it colorimetrically, there's great variability. So the first thing, as I've said time and time again, is serum B12 is not a good blood test. But this patient has a really elevated